let us focus on the public health prevention to improve the maternal health of a country. So, as a country, what government of India is doing to improve the maternal health, and so as to achieve the MMR of 70, which is a sustainable development goal, which has been agreed upon by the UN Assembly. So what we will be discussing upon for the next 40 minutes is what is the Indian and global scenario with respect to MMR, and what is the timing of maternal deaths and what really causing these maternal deaths. And we will lightly focus on what all those the interventions which have been implemented by Government of India, and lastly we will also focus lightly on what are the adolescent friendly health clinics which we call as youth clinics, what are the services being provided there, and also about menstrual hygiene scheme, and lastly a big program which is coming up which is called as Anemia Mukt Bharat. So before moving into the programs, I would like to just discuss about what is the difference between a maternal mortality ratio and mortality rate, because in all the first subsequent slides we will be discussing wherever it is MMR is coming, we would be talking about a maternal mortality ratio. It's not a maternal mortality rate, because there is a quite difference amongst the two. So maternal mortality ratio is the number of maternal deaths are happening per 1 lakh live births is being termed as maternal mortality ratio, and however the maternal mortality rate is the number of maternal deaths per 1 lakh women of reproductive age group. So from here on, whenever we are talking about MMR, please consider it as maternal mortality ratio. It's not a maternal mortality rate. So if we see the global scenario with respect to MMR, so there is so much of inequality with respect to MMR performance. So it is clearly been evident that all the sub-Saharan African countries are majorly impacted with this high MMR rates, and of course Southeast Asian countries including India and Southern Asian countries are equally lacking behind with respect to MMR, which means that there is a lot more to do to achieve the MMR of the SDG goals. So if we see all the American countries, North America, South America, and all the European countries, and of course North Asian countries, which are doing quite well and already been achieved the set targets earlier, which we call as Millennium Development Goals. So most of the countries have achieved, other than the sub-Saharan African countries and Southeast Asia and South Asian countries. So we can see here in sub-Saharan African countries that there are countries where has greater than 800 maternal deaths per 1 lakh live births, which is it is going beyond 1,100, 1,200 maternal deaths per 1 lakh live births, which is very high, and there is a lot more to do in the African countries. So if we have a look about what is the stark difference with respect to MMR in the developed countries and the developing nations, where the world average is wandering around 216 maternal deaths per 1 lakh live births. However, in the developed countries, it is only 12 MMR per 1 lakh live births, which is very low when compared to the world average. However, in developing countries, it is as high as 239 maternal deaths per 1 lakh. So it is very much inequality with respect to MMR. So it suggests that the health infrastructure available and the competencies and the quality services that are being provided in a country, because this MMR and IMR are the single most important indicators for understanding the health infrastructure and the quality of services of any country. So as we discussed, so if you see the average MMR of sub-Saharan African countries, it is as high as 546 per 1 lakh live births, and of course the Southern Asian countries and Southeast Asian countries, which is having around 180 and 110 of MMR respectively, which is again quite high when compared with the developed nations. So now we talk about sustainable development goals. So in the Sustainable Development Goals, all the member nations of the UN Assembly has agreed upon to achieve the MMR of 70 by the year 2030. So if we see now where are we standing, each country standing with respect to SDG. So again, the same countries which are lagging behind with respect to MDGs are same in the SDGs as well. So all the sub-Saharan African countries, South Asia and Southeast Asian countries are doing there to do of course, there are some countries in the South America where they need yet to achieve this MMR of 70 target. So just to give you a glance of the inequalities with respect to MMR globally, it suggests, the size of the bubble suggests that a severity of the MMR, the bigger the bubble, the higher the maternal mortality in that particular country. So all the rest of the bubbles other than, Asia and Africa are pretty low. European countries are doing very good. All the yellow color bubbles, all the green color bubbles are also, comparatively doing better, which are all the American countries. And of course, Australia, Singapore are doing pretty well. So Singapore is one of the best countries, having as low as only 3 per 1 lakh live births. So that's that they have the best healthcare infrastructure, and they are providing highest possible quality care to their citizens. So, however, in contrast, if you see Republic of Chad, Republic of Congo, they have almost 1,100 to 1,200 maternal deaths per 1 lakh live births, which is very high, and those mothers are really unfortunate to be able to not getting the minimal care and infrastructure which they very well deserve. And if we talk about India is doing fairly well with compared to Southeast Asian countries, which standing at around 113 maternal deaths per 1 lakh live births. So the recent estimates suggest that it is standing at 113. So what is the progress, global progress and Indian progress with respect to MMR? From the last 30 years, there has been humongous progress made with respect to MMR in our country. Whereas in the global, there was only 44% decline with respect to MMR, and it is standing around 216. But India, almost 80% decline has been registered when we count from 1990 to a present situation. The recent estimates of SRS, Sample Registration Survey, which will say that 113. So what are the targets for us ahead? The recently released National Health Policy 2017 has set a target of reaching 100 MMR by the end of 2020, which we are doing pretty well. Maybe in the year or two we will be able to reach this target, and of course we know this SDG goal of 17 by the year 2030. If we have just around the MMR situation in the southern states, definitely our southern states are doing a very good in compared to northern states. So all the southern states barring Karnataka stands in top 5. So Kerala being the first and Maharashtra being the second with 46, Tamil Nadu standing at 60 deaths per 1 lakh live births, and Telangana 63 and Andhra Pradesh 65 maternal deaths per 1 lakh live births, which suggests that these states have already reached sustainable development goal which has been fixed by the UN Assembly. But however, there is a lot more to do even in our states to further reduce the MMR and reach the MMR of countries. So from the last estimates to the recent estimates, there was a considerable decrease in the MMR for the state of Andhra Pradesh, Tamil Nadu, Telangana and Karnataka, and of course for India. However, Kerala could not reduce further, reported a slightest increase in the MMR, which has from 42 to 43. So now if we talk about the timing, in the inaugural speech of Dr. Lingaya has rightly mentioned that the intrapartum and the immediate postpartum period, the majority of the mothers are dying. Almost 46% maternal deaths are happening right from the time when the labor pain starts and is very much critical for the mother, where she will be with us. So as a midwife, as a nursing officer, we have a very good opportunity to early identify the complication and give proper pre-referral management and a timely referral, so that all the mothers can be saved, so that all the preventable deaths can be addressed. So it is, we can see the day one is the period when the most majority of the deaths happen. So what are the causes? Why are after all the mothers are dying? What is happening to them? So if we see the Indian average, all the mothers are dying. Amongst them, 27% of the mothers are dying due to hemorrhage, which is a very high number. Almost 30% of the mothers are dying due to hemorrhage. Because all the mothers are with us, because the institutional deliveries are almost at a 96-97%, so we have an opportunity to do something and avoid these deaths due to hemorrhage. So what can we do to hemorrhage? It is established evidence-based practices suggest that if we do a proper third stage of labor management properly by administering immediate oxytocin or misoprostol immediately after the delivery, but not before the delivery, we can definitely prevent so much of hemorrhagic conditions. And of course, having a blood transfusion facilities at all the places will always be helpful. And almost 11% mothers are dying due to sepsis and its complications. So what can we do to reduce the deaths due to sepsis? It is just conducting safe and clean delivery by following all the 6 cleans we know: the clean surface, clean cut, and so all this clean hands, so clean perineum. So if we try to adopt these clean methods, then definitely we can reduce these sepsis deaths due to sepsis. And of course, rationing of antibiotics and immediately timely identification of sepsis and administration of TT, of course, will help to a great extent, and following infection prevention protocols completely will reduce this deaths due to the sepsis. And almost 14%, this is the second leading most causal factor for the maternal deaths, hypertensive disorders and its associated complications. Whereas in Andhra Pradesh and Telangana, this is more than 14%. This is ranging around 20% of deaths with the hypertensive disorders, which Dr. Sarada has rightly explained, that early identification of the IBP and proper management with the antihypertensives, selective antihypertensives, and in case of eclampsia and severe preeclampsia, immediate administration of loading dose will solve the 90% of the problem then and there itself. So before the referral, in case of severe preeclampsia and eclampsia, administering a loading dose of MgSO4 is a life-saving procedure. So everyone should understand what is the loading dose of MgSO4 so as to do as and when it is needed. So almost 10% are deaths happening due to obstructive and prolonged labors. For this, the suggested intervention is to have continuous monitoring of the labor by plotting a partograph and only doing a LSCS for emergency conditions. And of course, almost 8% deaths are happening due to abortion, for which family planning counseling, because so many mothers don't know what to do to avoid the pregnancies. So we may feel that it is very a basic thing, but research suggests the other way. Almost 50% of the women in the rural areas, they don't know what to use, so as they end up in unwanted pregnancies. So they just use the unscientific methods to avoid that pregnancy and end up in the death due to unsafe abortions. It's an important role, and post-abortion care definitely will reduce these deaths due to abortion. And of course, the other causes like anemia, and GDM, placenta previa, antepartum hemorrhage, and all the systemic illnesses, definitely, which need to be identified and managed accordingly. So as we discussed, so onset of labor till immediate postpartum period is the period when the mothers are at the highest risk, and fortunately or unfortunately they will be with us. So we have an opportunity to identify the problems as soon as possible and do the corrective actions to avoid that complication. So for that background, given so many initiatives, implemented so many programs and initiatives right from 2000, the Government of India, since the inception of National Health Mission in the 2005, so many interventions has come up, capacity building initiatives, and further strengthening of infrastructure, like establishment of obstetric HDUs, ICUs, and giving Dakshata training and standardization of labor rooms, and facility-based neonatal care, and home-based neonatal and postnatal care initiatives, to name a few. So in the next 20 minutes, we will see what are the programs which have been implemented by Government of India across the nation. first to start with Janani Suraksha Yojana. This initiative was started in 2015. In the early 2000, it was observed that not so many mothers are coming for hospital to get delivered. So to improve the deliveries, government is giving incentive of 1,000 rupees for the women from the rural areas and for the 600 for the women from the urban areas to come to the hospital and to get delivered. And of course, for home delivery also, a 500 of incentive is being paid. So, including the encouraging for institutional delivery, what are the rest things which JSY has focused upon? JSY has focused upon early registration of the pregnancy and administering 2 doses of TT, getting an IFA and calcium supplementation, and getting a complete 4 antenatal checkups package, so that a woman addressed very comprehensively, and she would be very much ready to undergo a normal, safe delivery. So for all this getting done by the pregnant woman, Asha will be there to completely motivate her to undergo all these checkups and delivery. As will be paid performance-based incentives for getting pregnant women. So the next one which we will be talking about is Janani Sishu Suraksha Karakramam. Here, basic aim of this program is to have a zero out-of-the-pocket expenditure by the pregnant woman and her family, because we know that the mothers have so much of expenditure out of the expenditure for undergoing delivery or cesarean section if needed, which is leading to pushing them into the further poverty. So the government has started this, that every pregnant woman who is coming to the public health hospitals would be entitled to all free things, which include drugs and consumables, diagnostics including ultrasound scan, diet to the period when they are in the hospital, and blood transfusion charges, and free transport right from picking up to the delivery and dropping back after the delivery. So this money is not given to the pregnant woman, but this money is given to the facilities, hospitals, I mean to say, so that they can provide free services to the mother. With that program, all the mothers who are coming to the public health facilities no need to pay a single rupee for anything which they are expected to get a service from the hospital, including the cesarean section. Next, we will talk about Pradhan Mantri Surakshit Matritva Abhiyan, which called SM. This is the flagship program which been launched by the PM on PM. That the primary aim of this program is to identify the unregistered cases and to get the information of high-risk pregnancies as many as possible, to identify, to detect, and with a proper referral and follow-up of all the high-risk pregnancies. So the basic aim of this is the identification of high-risk pregnancies, and of course, getting into the system of unregistered pregnancies. So in this, what is happening every 9th of the month, every 9th day of the month. So this is considered as PMSMA day in all the public health facilities. Ashas and ANMs mobilize all the mothers to the health facilities and encourage to get it checked by the specialist, so that the any health high risk condition would be detected and a proper management mechanism would be devised. So every month 9th, this is being considered as a PMSMA day, and all the ANCs would be checked and high risks would be identified. So for this campaign, Ashas focus on, as I discussed, unregistered pregnancies, are any left out or missed ANCs, so that they will come into the system and get this comprehensive ANC package, and they will be getting a safe delivery in the institutions. In this PMSMA, the one checkup is mandatory in the 3rd trimester by the specialist, so that high risk can be identified early before the delivery, and an appropriate facility would be suggested to the mother. So next we will talk about Pradhan Mantri Matru Vandana Yojana, where this is a recent initiative by the Ministry of Women and Child Welfare, where the incentive of 5,000 rupees has been given for every mother who is undergoing a first delivery. All the primary mothers would be given a cash incentive of 5,000 to compensate the loss of wages by the pregnant woman and the family before and after the day. So how is this 5,000 is been given? The first installment of 1,000 rupees will be given after the early registration of the pregnancy. Once the pregnant woman gets registered in the system, they will get 1,000 rupees, and the second installment will get after the ANC in the third trimester, which we were talking about. So the 2,000 rupees she would be getting, and the third installment she would be getting once after the delivery, once the child gets a full first cycle of immunization. The last third installment of 2,000 rupees she would be getting. So these are all till now all the beneficiary schemes which are aimed to encourage the mother to come to the public health facilities and the seek care rather than getting delivered in the home, where the many complications and deaths were being identified. So far the government of India has been successful in mobilizing the mothers by having a system of ASHAs, ANMs, and all the pregnant women are being shifted to the public health facilities to undergo a delivery. Now the challenge is to ensure a quality services in the primary health facilities. So for that, as I mentioned, Dakshata is one of the program where all the service providers are trained and made competent to manage right from admission of the mother to the discharge after delivery, to follow all the evidence-based practices and avoid all these preventable maternal deaths. So as a part of that, the larger program, quality improvement program, which has been devised by Government of India, Lakshya. So this aim of this program is to improve and strengthen the quality of care which has been provided in the public health facilities, especially during intrapartum and immediate postpartum. Because as we have seen, this is the time when the mothers are at the highest risk. Almost 50% deaths are happening during this period. So this program completely aims to improve the quality of care in this period. So what is this program comprises of? So first, this program clearly defines the standards of care. What are standards of care which need to be abided so that the public health facility would be certified as Lakshya certified. So what are those standards of care which are already there? National Quality Assurance Standards, which we call as INQA standards, and Dakshata procedural standards. So for every evidence-based practice, there is a set of standard. Like for example, if we talk about examination on admission of the mother, there are set of standards like monitoring the vitals, taking the doing a vaginal examination in certain way, and doing an abdominal examination, checking for any danger signs. So these are all the certain set of standards to have a very good examination on admission. So as such, almost 19 standards were set up as a part of this to achieve a very good quality care in the hospitals. You should all refer to these modules, which are National Quality Assurance Standard module and Dakshata module. It is readily available in Ministry of Health website. So please download this, and it has a very easy to understand management, early identification of complications and management of complications, pre-referral management, what we need to be done before referral. So all these protocols are very neatly explained in a very simple manner. So please download these materials and refer. It is understandable. So this Lakshya program also envisages to make all the service providers competent with respect to the services they provide. For that, the government providing this, Dakshata trainings and a 7-day Daksh skill lab training, so that they become competent and confident to be able to handle that a mother who is coming with the labor pains till she goes happily after 48 hours from the delivery. And the major important component of this program is quality improvement, where there are certain themes in this, in which a facility forms a team, so that each thematic area would be discussed every month, and they will introspect and they will improve upon themselves with respect to all those 6 thematic areas, which we'll be discussing in the next slide. And the last component is respectful maternity care. So to provide the respect and dignity the mother deserves. So the major focus has been given under this program to be able to provide, get the public health facility a Lakshya certification. The mother should be getting utmost respectful maternity care in that hospital. So as a part of this, government of Andhra Pradesh has introduced a dress which is called a Matru Samman dress, where she would be having that separate gown while undergoing for normal delivery. So that her respect and dignity are very much addressed. So what are the goals and objectives of this program? So of course, to reduce preventable maternal and newborn mortality, morbidity and stillbirths by addressing all the complications and improving the quality of care by addressing the complications, timely referral and a very good pre-referral management, and of course enhancing the satisfaction of the beneficiaries by providing a very good woman-centric respectful maternity care. So these are the 6 thematic areas which I was talking about, where each thematic area addresses a particular services where that the highest quality would be ensured in the hospitals, where a first thematic area talks about tracking of labor with the partograph and having a proper documentation of all the records and reports. And the second thematic area talks about having a birth companion along with the mother and providing a very good respectful maternity care. And the third one talks about having a good assessment on admission and triaging the mother based upon her severity and abiding to all the management protocols. The fourth one talks about the very important to prevent a PPH is a third stage of labor, management of third stage of labor and rational use of oxytocin. Why are we saying here rational use of antibiotic, rational use of oxytocin? Because there is a predominant use of this oxytocin before the delivery, so as to fast track the delivery process, so that the baby is undergoing to severe distress and the baby is born asphyxiated and unnecessary complications to the baby, and of course for the mother with having a perineal tears and unnecessary other complications. So we should be using oxytocin very rationally only after the birth of a baby, immediately after the delivery. The fifth one talks about complication management of a baby with birth asphyxia, kangaroo mother care, and of course sixth one talks about infection prevention protocols, including biomedical waste management. So now we move on to very interesting the intervention which has been advised by the Government of India, which we call as Mother and Child Protection Card. So this is a card, entitlement card, given to the mother right from the registration, right at the time of registration, and that card contains the information from for the mother throughout the pregnancy, and of course to take care of the baby till the baby reaches the 5 years of age. So this card helps the healthcare providers to register all the details, so as the beneficiary gets all the benefits from the government, and of course to track the pregnancy and the health status of the mother throughout her pregnancy period. And of course the next 5 years the growth chart will be there, and all the different precautionary measures that need to be taken will be there in that card. So I would suggest, please, everyone should have the copy of this NCP card, which is recently released, updated one released by the Government of India. This has all the counseling material. When you go for a community visits in your as a part of your curriculum, you should be able to counsel all the pregnant women by using this MCP card, which is very informative and very easy to understand in a language. So how this card helps for the families, they can track how are they doing by having all the information on that. And that also gives the information on diet which need to be taken, and all the IFA supplementation, calcium supplementation, TT injections that need to be get by the pregnant woman, and of course taking care of the baby for the next 5 years, starting from immunization, growth monitoring, and precautionary measures for pneumonia, diarrhea, and feeding practices, breastfeeding importance. So everything this card contains. So I would request every one of you to have a copy of this and see and understand what is there in it. For of course for service providers, this would be as a tracking mechanism of what are the services already been provided, what is the anemia level of the mother right from the registration till the delivery. So everything can be tracked with this and can be recorded. So these are the major additions in the newly released MCP card, where all the information about JSY, JSSK, PMMVY, PMSMA are there, so that they would be entitled for all the benefits and home-based in child care and pneumonia, diarrhea, and nutrition and growth information, and of course danger signs in the antenatal period for the mother, danger signs in the postnatal period for the mother, and danger signs for the baby, in which time they should be again coming to the hospital. So these are already there in that, with a very good pictorial depiction. Of course, the information regarding family planning, IFM, deworming was also there. Again, I would request you to all go through this updated version and understand what are the things which are included in this. So we'll just have a word about mother and child tracking system. This is an online portal where all the details of the mother are being entered and would be tracked. See, the MCP card is the one on paper, and the same thing is online, is nothing but the MCTS. So this ensures the full antenatal care and postnatal care will be getting by the mother, and of course encourages every mother for the institutional delivery. So everything would be entered in this, and till the 5 years age of the children would track how is the mother, both the mother and baby are doing. So this has been launched in 2011, and if you see the mechanism how this works, so once the mother gets registered, the online portal which we call as a ANMOL, ANM online, so they will be entering all pregnant women details once she gets registered. And when she comes to antenatal care to the primary healthcare center, there the antenatal care details would be registered by the data entry operator. These things can be tracked at the district levels and state level, and of course at the national level, so that the proper decisions can be taken. For suppose the full immunization of a particular district is not happening, so immediately the corrective actions would have been taken. And if the mother is not getting IFA and calcium tablets, so that information can be tracked and taken corrective actions. So in this way, MCTS would be very helpful to take corrective actions and to ensure a full comprehensive care for the mother. Lastly, we will talk about this adolescent friendly health services, because every adolescent girl is a future mother, which is going to be a mother. And unfortunately, there are some adolescent period pregnancies are also being identified, which is again a very high risk. So to address all this youth clinics has been implemented by the Government of India in all the districts, where the wide range of services would be provided, where a counseling would be provided with respect to the changes in their bodies from the age of 10 to 19 population. These services would be available in these youth clinics. So what would be done in that? Monitoring of the growth and development of the adolescent, and any behavioral problems that would get that would be addressed, and information would be given on reproductive tract infections, STIs, and how to use contraceptives, and post-abortion care. Everything would need to be will be provided at these clinics. And of course, sexual violence and any substance abuse services will also be provided at these clinics. So along with, to address optimal health for the adolescent girls, there is also another scheme which talks about the menstrual hygiene, which is called as menstrual hygiene scheme. This primarily introduced to increase the awareness among the girls, so that menstrual hygiene is very important to ensure the optimal health, both to avoid any type of urinary tract infections or reproductive tract infections. That menstrual hygiene is very essential. So to increase awareness on that, and to increase the access, so they know that they should be using, but they don't know how to get from where they need to get. So to increase the access, the government is providing their sanitary napkins, and of course, because this is not a biodegradable material, so safe disposal is very much essential. So we should not dispose these anywhere. This should be properly disposed. Ideally, it should be incinerated. So what is this program do? These sanitary napkins at a very subsidized rate, these are being provided to the adolescent girls at a 1 rupee per sanitary napkin, which is 6 rupees per a pack. Of course, this ASHA's accredited social health activist. So these persons are responsible for distribution of these sanitary napkins. And lastly, I would like to bring your focus on problem of anemia in our country. This is one of the single most problem which is adversely affecting the maternal outcomes of the country. Where if you see all the age groups, children, adolescent girls, women of reproductive age, pregnant women, breastfeeding women, every target age group is having almost 50% of the population is suffering on average with some type of anemia, which is less than 11 milligrams percentage. So if you see the last 10 years, 15 years, there has not been much reduction in anemia. So this program called Anemia Mukt Bharat has been launched very recently, and a wide range of activities have been planned under this intervention, where weekly iron supplementation is also imbibed in this. So all these age groups will be provided a prophylactic IFA supplementation, and including that a deworming will also be done by giving a single albendazole tablet to all the children, adolescent and pregnant women, and of course women in the reproductive age of 20 to 24 years age group. And third intervention is to have a big IC campaign. So you can go to the site of Anemia Mukt Bharat. You will get all this awareness material you can use in your health education sessions. So that was very good information which is available. So please look into the Ministry of Health and Welfare website and Anemia Mukt Bharat website. There is huge amount of material available, which is very much informative for our better management of the communities. And the fourth intervention is large scale screening of all the age groups, so that the better management of all the people would be done. And the mandatory provision of IFA fortified foods. So this is one of the intervention innovation which will be introduced. So fortified foods with the iron, of course, already being implemented in some states, where in the PDS, public distribution system, where iron fortified rice would be provided, iron fortified wheat will be provided, so that the iron levels would be increased in the population. And non-nutritional causes also, like such as fluorosis, malaria, hemoglobinopathies, have a direct impact with the anemia. So there is a concentrated effort to address these effects as well. These are the different age groups which a prophylactic IFA tablets are being given, where 6 to 59 months of age syrup is being given, and 5 to 9 years 45 mg IFA tablet, pink tablet is given for every week, one tablet. And for all adolescents, 60 mg blue color tablet is given weekly one on all the schools, and out of the girls schools through Anganwadi centers it is being given. And also prophylactically for all the women of age group, reproductive age group in the age 20 to 24, also being given weekly IF tablet. And of course you all know that pregnant and lactating women will get 180 IFA tablets prophylactically, irrespective of their anemia levels. This is, I'm talking about prophylactic. Every mother, every woman, every adolescent girl will get these IFA tablets and have to get. So I would encourage, in fact, all the participants who are listening, as per their age, you should also be taking this prophylactic IFA tablets every week, one single tablet. I think end my session here with a statement that no mother should die while giving birth, and no baby should be born to die. Thank you so much.
So thank you.